behalf of Ampok, I welcome you all to this month's case presentation and an initiative of Ampok, which is taken up by ISMBO as well. So today, as you all know, we will be having we have changed the format a little bit different. Changed the format in the sense like henceforth we will be having one examiner from Kerala and one person will be from other part of the country, so that the students will get a better perspective of how the teaching is happening in other parts of the country, so that the student community will benefit out of this thing. So I request Dr. Arun Chandrasekhar to take up the proceedings to invite the examiners and the examinee. So over to you, Dr. Arun.
Thank you, sir. Thank you to everyone for joining in. So today we have a case presentation on CML by Dr. Joe, who's from RCC. And as our examiners, we have Dr. Hasmukh Jain, professor in Tata Memorial Hospital, Mumbai. Sir was my teacher as well, and my time I was there. So welcome to you, sir.
Thank you.
And we have also with us Dr. Sunu Siriak, who's who's a consultant and professor in Amala Institute, Thrissur. Dr. Sunu has trained extensively in clinical research and was in Princess Margaret for quite some time. Now he's come here and very active in research and teaching. So welcome to you, Dr. Sunu, as well. So I think I'll hand over the dais to the examiners. You can take over and ask Dr. George to proceed. Dr. Hasmukh.
Yes, please. Yeah, please go ahead. You can start your case presentation.
Good evening, respected faculty. I'll start off with my case presentation. Today, we're going to present the case of a 52-year-old lady who hails from Trivandrum. She's a homemaker, and she came with the chief complaints of pain abdomen for 8 months, early satiety for 5 months, and fatigue for 5 months. The patient developed pain abdomen 8 months back in her upper abdomen, which was insidious in onset, dull aching, non-radiating, continuous with no exacerbating or relieving factors. The patient also developed early satiety 5 months back, which gradually progressed in degree over this period. And the patient also noticed fatigue 5 months back, which gradually progressed in severity. There's no history.
Sorry, I just missed the age of the patient.
Sir, the age is 52 years old, sir.
Okay.
The patient had no history of fever or weight loss, no history of repeated infections, no history of any swellings, no history of bone pain or bleeding manifestations, no history of blurring of vision or headache. Coming to the past history, she had no similar symptoms in the past, no history of comorbidities like diabetes, hypertension, dyslipidemia, or CAD, no history of any surgery, no known allergies, and no previous malignancies. A personal history, there was a decrease noted in appetite, bowel and bladder functions were normal, her diet is mixed, and she has no addictions. Coming to the menstrual and obstetric history, menarche was at 13 years, menopause at 48 years, and the last menstrual period was 5 years back, and she's para 2, L2. Drug history, the patient is not on any regular medication. So just to summarize the history so far, she's a 52-year-old lady with no comorbidities, presenting with a history of upper abdominal pain since 8 months, early satiety since last 5 months, and fatigue since 5 months.
Sorry. So what's your localization with this history? Where do you localize the problem?
Sir, I would like to consider 3 possible DDs with this history, sir. One would be of chronic myeloproliferative disorder, sir. Second one, sir, I would consider a GI malignancy, sir. And third one, I'd consider an ovarian malignancy, sir.
Okay.
So
sorry, yeah, please go ahead, sir.
So you have confirmed that it's a malignancy.
Sir, given the age, the symptomatology and the chronicity of the symptoms, I would like.
If at this point you're asked to make a differential diagnosis, don't give differential diagnosis of malignancy alone.
Sir.
At this point, you don't have anything clearly to mention that's a malignancy. Keep the DD open.
Sir.
Yeah, so I mean, what you can make out from this is it's a relatively longish history. So there's definitely something which is going on, which is indolent. And the second thing is perhaps the localization. So since the localization is to the left upper abdomen, then you're looking with early satiety and fatigue. So you're thinking of spleen, you're thinking of stomach. So you're thinking of problems arising from either spleen or stomach. Considering an ovarian malignancy when the presentation is like this is a little bit of a stretch. So I would not consider that possibility. So you're essentially looking at some indolent problem which is affecting the spleen or the stomach. And then you have to consider your differential diagnosis based on this.
Sir.
Okay. And it may not be possible for you to always come up with specific entities. So it's okay. You can just leave it at that. And you can go on to your examination and then we can discuss the differential. The other point is in the negative history. What I would want to know is the reasons for the questions that you asked. Yeah, there if you stop. So your patient has come to you with left upper quadrant pain, patient has come with fatigue, patient has come with early satiety. So given these symptoms in a 52-year-old patient, how do these negative symptoms help you?
Sir, if I were to go ahead with that TD of a chronic myeloproliferative disorder, then these are basically, and if I were to consider that a DD, then these are negative histories show that to rule out blast crisis, to rule out any complications of a chronic myeloproliferative disorders.
See, as Dr. Sunu mentioned, you don't get fixated with the idea that this is only chronic myeloproliferative disorder. Even from a malignancy perspective, for a patient to come with splenomegaly, there are other possibilities as well. So CMPD is not the only malignancy that can present with splenomegaly. So that way, I mean, just don't get fixated with this idea. But yeah, I understand. So you need to ask for you're trying to ask for other constitutional symptoms, so fever, weight loss, and infection. Because patient has anemia, so you're trying to see whether the patient also has anything to suggest neutrophil dysfunction, and also bleeding will also help. So bleeding, infections, and weakness will basically tell about marrow failure. There's some problem happening with the marrow. What do you mean by no history of swelling?
So whether there are any lymph nodes along with that?
Yeah, that you have to be. Yeah, you have to mention that. So you're talking about any nodal swelling elsewhere in the body, and that is not only for CML with blast crisis. There are other entities also. Will come to them when you finish your examination. Okay. Why did you specifically ask for blurring of vision and headache?
Sir, if there's leukocytosis or thrombocytosis, then these symptoms can be seen, sir.
Right. So the second entity which you considered was CS stomach. But which, I mean, how do you rule out, or how do you rule in a CS stomach with this history or with this negative history?
Sir, I would like to add that there is no history of nausea, vomiting, no history of gastric outlet obstruction, and no history of weight loss has already been. So.
I mean, melena is another thing. So some of your colleagues have posted in the chat peptic ulcer with anemia. So I mean, like so evidence of GA bleed. So presence of melena would be something which would be useful. Abdominal TB is again somebody has posted in the group as one of the possibilities. So relevant history, keeping your differentials in mind, you should ask for the negative history as well. Okay. So again, nothing will. I mean, you said ovarian malignancy, but I don't know how that ovarian malignancy fits in here. So what is it that made you think that this could be an ovarian malignancy?
Sir, the upper abdomen pain is not really pertaining to that, but the early satiety and the fatigue.
Yeah, so I mean, the fact that the patient has a very specific symptom earlier, left upper abdominal pain, I think ovarian malignancy should not be considered, at least at this point of time. Okay. So yeah, I mean, I think it's a little non-specific. The symptoms are a little non-specific, so it's not possible to actually, may not be possible for you to come to an exact diagnosis, but perhaps, at least anatomically, you can localize that this is either a problem happening with the spleen or with the gut. And keeping this in mind, you should proceed with the examination. Dr. Sunu, any comments there?
Yeah, just one comment is that's basically related to why we should keep these things open is basically when we're practicing in an oncology center which receives patients directly also without referral, you should always keep your mind open for anything benign or non-malignant etiologies also. So even if you're an oncologist and the patient is coming to you, there might be some scattered reports or some FNAC showing some atypical cells. Don't always jump into a conclusion of malignancy.
Sir.
keep the idea of benign things also always open.
Sir.
Okay, proceed.
Coming to the examination, the patient was examined in a well-lit room with consent and with a female chaperone. She is conscious, or cooperative, and well-oriented time-patient person. She had an Eastern Cooperative Oncology Group score of 1. And further examination, pallor was present. No palpable lymphadenopathy was seen, including supraclavicular nodes, no gum hypertrophy or gum bleeding, no pedal edema. Coming to the vitals, all our vitals were stable and within a normal range. Coming to the abdominal examination, on inspection, the shape of the abdomen is normal. The umbilicus is central and inverted. All quadrants move equally with respiration. There's no visible lump, fullness in any quadrant, no engorged veins, and no visible pulsations. Coming to the palpation, there's no local rise in temperature, there's no tenderness, and the spleen is palpable 10 centimeters below the left costal margin, extending downwards and medially, firm in consistency, smooth surface, moves with respiration. All the borders are felt except for the superior border. The splenic notch is felt and it's approaching the midline. There is no hepatomegaly, there's no other palpable mass, and there are no pulsations felt. Coming to the percussion and auscultation, there's a dull note found in the left hypochondrium. There's no shifting dullness. The normal liver span, of 12 centimeters is seen, and no splenic rub is heard. Other systems were examined and were found to be in normal limits. To summarize the history and the examination, we have a 52-year-old lady, postmenopausal, with no known comorbidities, not on any medication, presented with complaints of abdominal pain since 8 months, early satiety since 5 months, and fatigue since 5 months. On examination, she was found to have pallor and splenomegaly.
Okay. So what's the differential now?
Sir, given that the patient is a 52-year-old lady and she has these symptoms, and considering the chronicity of the symptoms and considering the presence of splenomegaly that's almost approaching the midline, sir, I would like to make 3 DDs come to mind, sir. One is that of, once again, a chronic myeloproliferative disorder. Secondly, I would like to, with these findings, I'd like to think of hairy cell leukemia. Third, I'd like to think of splenic marginal zone lymphoma.
Okay.
If I say this patient is having cirrhosis with portal hypertension, how would you say against that?
Sir, I would like to, I would like to, first of all, rule out in the history, like to rule out the etiology for the portal cirrhosis and portal hypertension. And if that's not possible, then I can also look for associated features, including ascites and for varices, especially around the periumbilical area.
The patient might be much more emaciated. The liver might not be palpable. Definitely, if it's cirrhosis, it might get shrunken. Might be a bit more sick looking, and the patient might give history of melena and symptoms, etc. You told about ECOG performance status. What are the other performance status that you know?
ECOG and Karnofsky performance status is the 2 ones that we commonly use.
Uncommon?
Sir, WHO performance status is there, sir, and pediatric class performance status.
Okay, what is the comparison between, or how do you equate between Karnofsky and ECOG? 1, 2, 3, 4 equivalent to what?
Sir, ECOG 0 is equivalent to Karnofsky score of 100, and ECOG 1 is equivalent to Karnofsky score of 90 and 80. 90 and 80, and ECOG 2 is equivalent to Karnofsky score of 70 to 50, and
60 might be.
60, sir. And ECOG 3 is equivalent to Karnofsky score of 50 to 50 and 40, sir, and ECOG 4 is
40.
below that, sir.
Okay.
So what does PS1 indicate?
Sir, a PS1 ECOG 1, sir, indicates that the patient cannot do physically strenuous activity, but can go about homely work as well as office work, and the patient is able to take care of her personal needs as well, sir.
Right. Okay.
So now suppose we ruled out most of the benign things, keep it apart. Now let's come into pure oncology. What are your oncological differential diagnosis was with pallor and splenomegaly, moderate to massive splenomegaly?
Sir, I would like to first of all consider a chronic myeloproliferative disorder, sir.
Which amongst them? So chronic CMPD is a very broad term. Which are the entities that you're considering here?
Sir, here I'd like to consider, sir, chronic myeloid leukemia, sir, and myelofibrosis, sir.
Okay.
The other one's not so much. The polycythemia, sir, polycythemia vera, there's pallor, so that can be.
The massive splenomegaly is not a feature of polycythemia vera, and neither it's a feature of essential thrombocytosis. So that's fine. So you're looking at CML or myelofibrosis. Okay. Move on.
Sir, apart from that, sir, I would like to consider hairy cell leukemia and splenic marginal zone lymphoma, sir.
Okay. So both of them fall under the category of lymphoproliferative disorders. So you're looking at chronic lymphoproliferative disorders. Okay. Any other malignancy?
Sir, apart from this, there are a few rarer ones that, sir, I would like to mention, sir. CMML, chronic myelomonocytic leukemia, can present with this picture. Sir, then hepatosplenic T cell lymphoma can also present with this picture, sir. Sir, and also, although not as commonly, sir, lymphoplasmacytic lymphoma can present with this picture, and few low grade B cell malignancies. Like indolent variant of mantle cell lymphoma.
Okay.
Sir. And so those are my.
Right. So just there are some features which will help you, or which indicate that this is one of these entities. For example, what makes you think that this is CML?
Sir, CML mainly because, sir, there is massive splenomegaly, the chronicity of the symptoms, and the fact. So the symptoms as such, the chronicity of the symptoms, and the presence of massive splenomegaly, without any other symptoms apart from that.
Okay. Myelofibrosis.
Sir, coming to
Myelofibrosis. Any pointers for particularly in favor or against myelofibrosis?
Sir, pallor and splenomegaly, that combination is a possibility, sir. Chronicity of symptoms, sir, can also be seen especially if it's a transformed myelofibrosis.
Not necessarily. So any primary myelofibrosis in the early stages, early phases can have can present or will present with chronic symptoms rather. So there's nothing that is particularly against the diagnosis of myelofibrosis. Myelofibrosis is perfectly an acceptable possibility here, right? Okay. Sure. What about the CLPD? So you listed out the whole bunch of CLPDs. Which is the CLPD that is most likely, or just purely based on the incidence, which one is the most likely?
Sir, chronic myeloid leukemia, sir.
No,
LPD.
Sir, CLPD, sir. Sir, the CLPDs that I mentioned are all rare.
Yeah.
I would consider hairy cell leukemia.
Perhaps hairy cell leukemia, mantle cell lymphoma, and SMZL. These are the ones that you'll probably consider. So anything that tells you that why this is hairy cell leukemia, why this cannot be hairy cell leukemia, anything in particular?
Sir, the hairy cell leukemia, usually you get a pancytopenia picture with splenomegaly, sir. Here there is a cytopenia here, sir, and there is splenomegaly, sir. And the chronic.
Can you have hairy cell leukemia without splenomegaly?
Sir, it is possible, sir. Although it is the most common symptom, it is possible, sir.
Yeah, and up to 1/3 of patients, you can have hairy cell leukemia even without splenomegaly. Okay. So is lymphadenopathy a feature of hairy cell leukemia?
Sir, it is also a symptomatology. So there are no lymph nodes that are palpable, sir.
No, I'm asking whether lymphadenopathy is a feature. Is it a prominent feature of hairy cell leukemia?
Sir, it is not as common as hepatosplenomegaly, sir.
But is it seen at all? What kind of lymphadenopathy, or which particular lymph node is enlarged in hairy cell leukemia? See, hairy cell leukemia is a lymphoproliferative disorder. In a lymphoproliferative disorder, you expect you expect lymph node enlargement. So, is it true in hairy cell leukemia?
Lymphadenopathy can be seen, sir.
No, it's not seen. In fact, retroperitoneal nodes perhaps are the only site where which can be enlarged, but generally you don't get peripheral lymphadenopathy. So if you get peripheral lymphadenopathy, hairy cell leukemia becomes less likely. Okay. That's why you're considering hairy cell leukemia. Otherwise, you could have even considered CLL. Why are you not considering CLL in this patient?
Sir, there's no peripheral lymphadenopathy, sir.
Yeah. Now, suppose there is a patient who has lymphocytes, mature lymphocytes looking like CLL, but then the patient has only massive splenomegaly sick looking. There's no lymphadenopathy. So what is the closest differential? So exactly, morphologically might look like a mature lymphocyte. Patient will not have lymphadenopathy, unlike a CLL, but can have moderate to massive splenomegaly. So what's that entity?
So the patient is sick, sir.
Usually sicker as compared to the CLL presentation. So prolymphocytic leukemia can sometimes present like that. Okay, so when you have a CLL-like morphology reported on the smear, but there are no significant lymph nodes. On the other hand, you are having a bigger spleen. You should consider the. Okay. Yeah, and then mantle cell lymphoma again can present with massive splenomegaly. This is an unusual presentation, but you can have mantle cell lymphomas presenting like that, and so is SMZL. Again, interestingly, both SMZL and mantle cell lymphoma may not have significant peripheral adenopathy, so they can just present sometimes with massive splenomegaly. So that's why, yes, these entities we'll have to consider. But what is odd for a hepatosplenic gamma delta T cell lymphoma?
Sir, it's a very aggressive disease, sir.
Yes.
And the chronicity of the symptoms don't suggest.
So it's an aggressive disease, generally seen in younger patients. You will have hepatosplenomegaly. Patients will have cytopenias. They'll be sick. So you will not get a patient with 8 months history and then the patient will be stable. That is very unlikely for a hepatosplenic gamma delta T cell lymphoma.
Sir. Do you consider any plasma cell dysplasias with a splenomegaly, not massive?
Sir, I can think of, sir, Waldenström macroglobulinemia. Sir, it's a possibility, sir.
Do you consider that in here?
Sir, although the symptoms can, sir, here, sir, against that, sir, I would like to say there's no features of hyperviscosity that were reported in the negative history, sir.
What's Poem syndrome?
Sir, Poem syndrome, sir, is it's a syndrome in which there is a polyneuropathy, organomegaly, endocrinopathies, as well as M spike that's seen, sir.
Okay. Shall we go into the next?
Yeah. So what is the next? Yeah.
Sir, investigation, sir.
Yeah.
Sir, investigation, sir, we did a complete CBC. The hemoglobin is found to be 8.8. The platelets were 5.58 lakhs, and the total count was 1.89 lakhs. We did a differential count. The differential count showed that neutrophils were 73%, lymphocytes were 3%, eosinophils and monocytes were 0%, and there were 13% myelocytes and 2% band forms that were seen. The peripheral smear showed neutrophilic leukocytosis with shift to the left, with eosinophilia, basophilia, and blast of 3% with normocytic normochromic anemia. So
with this report, which entire bunch of differential diagnoses are removed?
Sir, sir, with this report, I'd like to take out. I'd like to rule out the other myeloproliferative neoplasms that we had listed, sir, and it's heading towards CML.
It's heading towards a myeloproliferative disorder. Lymphoproliferative disorders are out of question now.
Yes, sir.
This report, don't expect a lymphoproliferative disorder now. Okay.
You mentioned that the peripheral smear was. Sorry, go ahead. You mentioned that the peripheral smear was showing shift to left. What does that mean?
Sir, shift to left means, sir, the granulocytes that are seen are more of immature forms, and meaning more of promyelocytes, myelocytes, metamyelocytes, and band forms, sir.
What is that? Can you just tell in one sentence, what are the series of lymphocyte WBC neutrophil maturation?
Sir,
how does that progress?
sir, there's myeloblasts, sir, promyelocytes, metamyelocytes and band forms, then the mature forms, sir.
Okay. So, have you heard about the term leukomod reaction?
Yes, sir.
How does the peripheral smear look like in that?
Sir, in peripheral smear and leukemoid reaction, sir, we might see a neutrophilic leukocytosis, and there is also a shift to the left, sir. But there is no myelocyte bulge that's seen. That is, the metamyelocyte is more higher than the myelocytes. Sir, and apart from that, sir, there's no eosinophilia or basophilia that's seen in most cases of this leukemoid reaction, sir.
Okay. And what else might help to differentiate a leukomod reaction?
Sir, the total count won't be this range, sir. It will be around 50,000, sir. Sir, apart from that, splenomegaly is not commonly seen, whereas in CML it's commonly seen, sir. And most importantly, sir, lab score can be leukocyte alkaline phosphatase score can be used. In CML, it is usually less than 13, whereas in leukemoid reaction is more than 130, sir.
Okay.
So how would a myelofibrosis appear on the peripheral smear and blood? What would be the blood counts as well as the peripheral smear and the myelofibrosis?
Sir, in case of a myelofibrosis, sir, there would be, sir, there can be, sir, erythroleucoplastic picture.
Start from hemoglobin. So what happens to hemoglobin in myelofibrosis?
Sir, pancytopenia can be a presenting feature of myelofibrosis, sir. So anemia and thrombocytopenia can be seen, sir.
So you could see anemia. Platelets could be normal. They could be elevated also. Only it's in the later phase when the platelets start dropping. The WBC counts will be normal. It will be elevated. It will not be low. Okay. So you see leukocytosis. You don't see leukopenia. Not in the at the initial presentation at least. Okay.
Sir.
And what happens to the peripheral smear?
So the peripheral smear, there's marrow fibrosis, sir. Reticulin. Sorry, sir. Peripheral smear, there's sir. So in the peripheral smear, there is anemia that can be seen, and leukocytosis, and apart from that,
Morphology, do you see anything? Have you heard of something called leukoerythroplastic picture?
sir, leukoerythroblastic picture, sir, seen as well, sir.
So that is what you get in a. So you don't get such high counts. You don't get 1,89,000 in a myelofibrosis, but you do get leukocytosis. Okay, and a peripheral smear again is important. Differential is important because as the disease evolves, the blast percentage can increase. You generally have low blast percentage in the early phases, but gradually, particularly when there is a leukemic transformation, the blast percentage can go up. Okay, so that's a picture in the myelofibrosis. Right. Okay, what's next after this?
Sir, I've got the remaining investigations.
What investigation do you order after when you see this report? What investigation do you order next?
Sir, the next investigation that I'd like to order, sir, is a bone marrow study, sir.
What do you do?
Sir, a bone marrow aspiration and imprint, and a bone marrow biopsy is warranted, sir.
Okay.
And sir, should I enumerate, sir, the bone marrow?
No, what test do you what do you ask? You look at the morphology. What else do you ask?
Sir, in the bone marrow aspiration and imprint, sir, I would like to, sir, look at the morphology, confirm the findings in the peripheral smear, sir. Look at the percentage of the blast, sir. Look at the percentage of the basophil, sir, because that could possibly alter the diagnosis, sir.
Right.
And apart from that, I would like to send a conventional cytogenetics as well, sir.
Okay. And what else? Would you like to do a molecular study? Would you like to do a PCR for PCR?
Yes, sir. Apart from that, sir, I'd like to mention a few more things. Sir, bone marrow biopsy, sir, I would like to look at fibrosis, sir, as well as if there are any clusters of blasts, sir.
Right.
That will also contribute, sir. Sir, following all of this, sir, what I'd like to do is, sir, I'd like to order a qualitative RT-PCR for BCR-ABL, sir, as well as a fish for BCR-ABL, sir. A dual probe fish, sir, for BCR-ABL.
Why do you want to do all the three? Why do you want to do fish, PCR, as well as conventional karyotyping?
Sir, sir, if sir, if I may, sir, as far as I've read, sir, in our center, sir, we do fish because, sir, the turnover time for conventional cytogenetics is very late, so we can't wait for a pH positive confirmation with conventional cytogenetics, sir.
Right.
Sir,
But then why do you do a PCR?
Sir, PCR is to check if the BCR-ABL transcript is present or not, sir, and we do a qualitative PCR to check the same, sir.
But that information you get even from fish, right? So if fish shows that there's BCR-ABL translocation present, then why do you want to check that whether there's a fusion present again by another technique?
Sir, the type of fusion is, sir, can be.
So the type of transcript is what you're looking at, because your monitoring will depend on the type of transcript present at baseline. Okay. So what additional information is CK giving, which is anyways going to come late? So what's the point of doing a CK?
Additional cytogenetic abnormalities can be seen, sir, and that's important, sir, because it can alter the therapy, alter the stage of the disease as well, sir.
Okay. What additional cytogenetic abnormalities you know?
Sir, there are major root cytogenetic abnormalities, sir. Sir, these include additional PH chromosome, sir. Then isochromosome 17, sir, and trisomy 8 and 19, sir. So then there are additional ones like 3Q arrangement, sir. Then also, sir, there's 3Q arrangement. There is monosomy 7, sir. Deletion 7Q, sir.
So suppose now you don't have the facility to do a conventional karyotyping. In what proportion of patients otherwise labeled as CML-CP would you miss out an accelerated phase, or would you miss out an additional cytogenetic abnormality at baseline? In
Sir,
other words, what is the additional incremental value of doing a CK over and above all the tests that you're doing?
sir, it is around less than 5%, sir.
Yeah, it's less than 5%. So many centers actually don't do it and don't have the access. So but yeah, you have to remember that less than 5% of the patients will have an additional cytogenetic abnormality and they could get reclassified. Okay.
Sir.
Right.
So you did the qualitative BCR-ABL to find out the type of transcript.
Sir.
What are the type of transcripts?
Sir, the three most commonly, the major, minor, and sir, the transcripts are, sir, there's P210 transcripts, sir. Translocation between exon 13 and A2 and exon 14 and A2. So that's commonly seen in CML, sir. Sir, and then there's P190 transcript, sir. That is translocation, balanced translocation between E1 and A2, sir. That's commonly seen in, sir, pH positive acute leukemia, sir. And
what do you mean by balanced translocation?
Sir, equal genetic material is exchanged between both the chromosomes, sir.
There's no loss of genetic material between
Yes, sir. Sir, and then, sir, P230 is there, sir. Apart
what
from
are
that,
these numbers? What does this number signify?
sir, the molecular weight, sir, kilodalton, sir.
Okay, so next slide. You did all this.
Sir. Sir, may I proceed, sir?
Yeah.
Yes, yes.
So we did a bone marrow aspirate and imprint, and it showed a cellular marrow with an increase in the myeloid and erythroid ratio of 20:1. And there's myeloid hyperplasia with increase in myeloid precursors. The blasts were 1 to 2%. The basophils were 3%. The eosinophils were 4%. And megakaryocytes were adequate. Bone marrow biopsy, marrow shows myeloid hyperplasia with increase in precursors and eosinophils. And the erythroid CS is reduced. And megakaryocytes are increased in number and normal with few dwarf forms. We did a conventional cytogenetic study, and it showed a balanced reciprocal translocation between long arms of chromosome 9 and chromosome 22. FISH was done, which showed that 95% of cells are positive for BCR-ABL, and a qualitative PCR assay was done for the peripheral blood, which revealed presence of fusion transcript BCR-ABL B2A2 type.
So what is the normal myeloid erythroid ratio?
So normal myeloid 2 to 3, 2:1, sir.
3:1. Okay. So it does not have myeloid hyperplasia with increase in myeloid precursors. Blast. So what is the conclusion from this? Is there any dysplasia in this?
Sir, there's no dysplasia, sir.
Did you check with your pathologist whether there was dysplasia?
Sir, to be honest, I did not check that. Sir.
What are the features of dysplasia in a marrow or a peripheral spleen?
Sir, the features of dysplasia include a high NC ratio and
What is it? Okay.
so high NC ratio and clumping of the chromatin and
So there are features related to the erythroid series, myeloid series, megakaryocyte. That is something that you might use in MDS classifications, etc. also. Where unilineage or bilineage or trilineage dysplasias. The feature specific for the peripheral blood as well as for the bone marrows also.
Sorry.
Look all into this because that will help a lot in the differential diagnosis also.
sir.
What might be the major differential diagnosis before the karyotyping for these patients?
Sir,
With a high count, myeloid high counts.
Sir, just based
Just
on
myeloid high count, nothing else.
sir, just based on the myeloid high count, sir, it could
One was leukemoid reaction you mentioned.
leukemia reaction, sir. Sir, apart from that, sir, polycythemia vera, essential thrombocytosis can also present with.
I'm asking WBC counts only high.
Okay, sir. Sir, myelofibrosis can also present with
Okay.
leukocytosis, sir. Sir, and then of course, sir, with WBC only high, acute leukemia has to be
Right.
ruled out.
More of an acute presentation.
Yes, sir.
What is CMML?
Sir, chronic myelomonocytic leukemia, sir. Sir,
How does that differ?
Sir, sir, the diagnosis, sir, there's monocytosis, sir. So the differential monocyte count will be greater than 1000 per microliter, sir, and it will constitute more than 10% of the differential count. Sir, apart from that, sir, there will be sir, 1 second, sir, if I may recollect.
Yeah.
Sir, apart from that, sir, the pH positivity won't be seen, sir.
Yes,
And-
positivity won't be there, and that is one condition where you might get a lot of dysplasia also.
In one of the cell lines, sir.
So start learning to look into the dysplasias in the peripheral smear and bone marrow when you get from a pathologist. Specifically look into those things. They might not have focused a lot, but that might give some clues to some other things also. Okay, you did the qualitative PCR. Didn't you do a quantitative PCR?
Sir, the quantitative PCR, sir, since you're doing it at baseline, it won't give any additional information, sir. We are just trying to establish the presence of the transcript, sir.
Okay. How do you quantify the PCR ABL?
Sir, when we are quantifying the PCR ABL, sir, we use the international scale, sir. And so the international scale is the baseline values of the patients treated in the IRIS trial are used, sir. And the response to treatment is quantified as using that as the baseline, sir. Using that as 100%, sir.
Okay. So you make it to 100% using an international standard that is available.
Sir.
So what's a good sample? So when you read a report for of PCR for PCR ABL, how do you interpret? How do you say that the sample was good and the test run was sufficient or adequate?
Sir,
So do you look at something else as a comparator? Is there any comparator gene being amplified? And
sir, ABL1 gene is amplified. So normally ABL1 gene, or sir, I read about this. Practically, sir, I seen ABL, then GUSB gene is also amplified.
it depends. That's a center-to-center practice. So some people use. So basically, you have to use a housekeeping gene as a control, and to show that this test has run successfully, and it's not just a. It's not that the test has failed or the amplification has failed. You need to show that at least the housekeeping gene has amplified sufficiently. When the housekeeping gene is amplified, and then you look at the BCR ABL numbers. So you need to have at least 10,000 copies of ABL gene, and then in that context, you need to interpret your report. Okay. Now, why is this dual fusion fish used here? Why not a break apart probe? So where do you use? Do you know any instances where you use a break apart probe?
Sir, if there is sir, for example, in Ewing sarcoma, sir, but
Hmm.
there's a common gene that's translocating with multiple other genes, sir.
Yeah, so that's an indication. So when you have multiple possible partners for a particular chromosome, for a particular gene, that's when you use it. You use a break apart probe. Whereas in BCR-ABL, you use a dual fusion probe. Okay, right.
Sir.
Okay, what next after this?
Sir, after
You've
this,
done a
sir,
CBC, you've done a marrow. What else do you want? What about other information you need?
sir, apart from this, sir, I would like to, sir, before that, sir, I would just like to make the diagnosis, sir. Sir,
What's the diagnosis?
sir, it looks like it is confirmed to be a chronic myeloid leukemia, chronic phase, sir. And sir,
Okay.
I calculated the risk stratification for this patient, sir. And
Right.
the Hasford and the ELTS score, sorry, the SOCAL and the ELTS score came out to be high risk, sir.
Okay.
SOCAL
What
and
other- Yeah, it is.
ELTS. Okay. What is ELTS?
Sir, ELTS is, sir, UTO's long-term survival score, sir. Sir, it consists of, sir, age, spleen size, platelet count, blast percentage, sir.
Among this, which is the better?
Sir,
What
ELTS.
would you think is better?
Sir, ELTS was made in the TK era, sir, and actually the SOCAL score it overestimates the impact of age, sir. Whereas the ELTS score gives us a better. The SOCAL score upgrades a lot of low risk into intermediate and high risk, whereas ELTS score is more appropriate for the TK era, sir.
So both of them has got how many strata?
Sir, low, intermediate, and high risk, sir.
Okay. Go ahead.
Sir, my final diagnosis is chronic myeloid leukemia, chronic phase, high risk, sir.
What are the features of accelerated phase?
Why
did you say that this is not an accelerated phase?
Sir, I will stick to the ELN criteria, sir. Sir, based on that, sir, the blasts in that of 15 to 29%, sir. Sir, and then the blast plus the progranulocytes are greater than 30%. Sir, apart from that, basophils are greater than 20%. So these features are not seen in the marrow.
So in your institution, are you still practicing that 25% of blast will be considered as accelerated phase?
Sir, we are moving towards the ELN criteria, sir, because in the WHO criteria, especially it has been shown that between 20 to 30%, they have a better prognosis than the ones that are greater than 30%, sir. So it is more appropriate to the outcomes of the patient, sir.
Okay. And then one is blast, then?
Sir, blasts are basophils, sir. And then the progranulocytes and blasts are greater than 30%, sir. Sir, apart from that, sir, then additional cytogenetic abnormalities is also, sir, now seen as in the AP phase, sir. Sir, apart from this, sir, there in the WHO criteria there are some provisional criteria as well, sir. Sir, should I mention?
Yeah, please.
Sir, that is there are two or more mutations seen in the BCR-ABL domain. If the patient does not achieve complete hematological response at 3 months, or if the patient has hematological, cytogenetic, or molecular failure with 2 or more TKs, sir.
Anything related to the clinical features?
Sir, I just need time to recollect, sir.
Okay, fine. Let's go ahead. Yes. And blast crisis?
Sir, in blast crisis, sir, greater than 30% blast, sir. Sir, and the presence of extramedullary blast proliferation, sir, is.
Okay. Even with a marrow which is looking like chronic phase.
Yes,
if there is an extramedullary, you can call it as a blast crisis. In a blast crisis, what are the types of blast crisis that you can get?
Sir, most commonly a myeloid blast crisis is seen, sir. followed by a lymphoid blast crisis, sir. And then also you can see a mixed phenotypic blast crisis as well, sir.
What proportion would be a myeloid blast crisis?
Sir, more than 2/3 are myeloid blast crisis, sir.
Okay.
So what next investigation?
Um,
Want any more investigations, or do you want to start on treatment?
Sir, I would like to, at this point, sir, if I may, I would like to decide further investigations based on how I'd proceed treatment. But sir, one thing I would look for is the RFT and the serum electrolyte, sir. Although uncommon, sir, and in this scenario it is uncommon, sir, but TLS can also be a feature, although it is uncommon, sir.
What else do you want to see, man? Only RFT and electrolytes, or anything else also you want to see?
Sir, the LDH is also a prognostic factor, sir. Sir, further investigation, sir. Based on,
Will you not see an LFT?
sir, LFT and RFT.
You're talking about PCR and that and this, and you're not even talking about LFT. So suppose this patient has 5 times elevated OTPT. Will you give this patient TKI?
Sir, coming to the TK, sir, I would for each TK, I would like to plan depending on the TK that I'm planning, sir. I would like to.
So is that how you do the workup? Is that how you do workup? That you first do a CBC, get a marrow, get everything, and then you start doing a biochemistry? Is that how you do workup in your center?
No, sir. We
then
do
talk
the
logical things. No, talk the way you do your workup. Don't talk things like what is written in the textbook. Okay, you do LFT, you do RFT on the day one. You get your marrow. Once your marrow is done, you can, if needed, you do additional investigations. Some of the investigations even you can do at baseline as well. So, for example, a lipid profile, a blood sugar, ECG can be done even at baseline. Nobody is stopping you, but that practice could vary. But to not mention RFT, LFT is little.
Sir, RFT, LFT definitely.
Yeah. What TLS happens here? You don't get TLS, you get hyperuricemia. You could get isolated hyperuricemia in these patients. That is something which can happen. Okay. Okay. So, I mean, doing an LDH is fine. It's not going to add anything in your management. So, what additional investigation you want to do now? Given this is a high risk CML CP.
Sir, like you mentioned, sir, LFT and RFT and serum electrolytes, sir. Following that, sir, I would like to do a lipid profile, sir. I would like to do an HbA1c, sir, and a fasting as well as postprandial sugar profile, sir. Sir, I would like to do a baseline echo, sir, with
routine
ECG
practice
as well, sir. Sir, in this particular case, sir, I would like to do a baseline echo ECG, especially if I'm depending on the TK that I'm going to give, sir. I would like to do it. So this.
Okay, let's come to the TK first. Okay, let's make it simple. How will you decide what TK do you want to choose in this patient?
Sir, this is a high-risk patient, sir. So I would counsel the patient more towards a second-generation TK, sir.
Okay. Which one?
Sir, either one of the three can be given dasatinib, nilotinib, or bosutinib, sir.
Tell me, choose one. Which one do you want to select in this patient?
Sir, I would go with dasatinib, sir.
With what dose of dasatinib do you want to use?
Sir, 100 mg, sir.
This is on the basis of what trial? How do you decide on dasatinib here in this patient?
Sir, dasatinib trial.
So what is the trial about?
So the trial compared dasatinib 100 mg versus imatinib 400 mg in CML CP patients, sir. Sir, and the trial came to the conclusion that there was faster response as well as deeper response, along with a decreased rate of conversion to advanced phases of CML, but there was no PFS or OS benefit as compared to imatinib, sir.
Right. And so, what was the difference in terms of conversion to AP and BC between the two arms?
Sir, it was roughly there was a 50% reduction, sir. 6% to, sir, if I remember correctly, sir, 3 to 4%, sir, in the dasatinib.
3 to 4% of what?
Sir, in the imatinib arm, sir, it was 6%, sir.
What?
Sir, conversion to advanced phase.
Okay, transformation. Okay.
Yes, sir. Sir, and in dasatinib arm, it was, sir, I don't remember exactly, sir, 3 to 4% is what I remember.
So now tell me, in this patient, no, she's a 52-year-old. What is your primary endpoint of interest in this patient? Like, what is the outcome that you're interested in? Are you interested in a survival outcome? Are you interested in rapid conversion, rapid remission? What is it that you're interested in?
Sir, I'm not so much interested in a rapid response, sir. I'm more interested in possibly achieving a complete cytogenic response, and then the survival of the patient is more important than a rapid uh, response. Considering her age, sir, and the fact that she has already 2 children, she's postmenopausal, sir.
Okay.
What
So
is
you're
menopause to do with this?
Sir, if the patient is still willing to have another pregnancy, sir, then, sir, if I may, sir, we might be interested in a treatment-free remission, sir. In that case, we might want to achieve a faster response. So in that case, we might need a faster response in that case, sir.
Okay, so basically, see, your endpoints of interest is survival. Then you're looking at achieving the milestones. I mean, achieving deeper milestones and rapid milestones. And then third thing is you're looking at a risk of progression into an APMBC. So in an elderly patient, perhaps overall survival will be a more important outcome. So it doesn't matter whether you reach your milestones at 12 months or 18 months. It will not be so important at a 52-year-old patient. The only strong argument is that the patient will have a high risk of transformation to APBC. And if there's a high risk of transformation to APBC, then the salvage rates after that is very low. So that is the argument to say why you want to use dasatinib. Of course, in the absence of other comorbidities. So patients should not be having certain comorbidities. So when you're choosing dasatinib, what comorbidities are you interested in?
Pleural or pericardial or pulmonary comorbidities should be excluded, sir.
Right.
Pulmonary hypertension should be excluded, sir.
Okay.
So then, apart from that, although not as prominent, still we should look at QTC interval, sir. And patients with patients are with diabetes, hypertension, and dyslipidemia. Sorry, sir. Sir, patients with COPD, sir, patients with pre-existing pulmonary pathologies or pleural pathologies, they should be ruled out, sir.
Right.
Have you ever looked into the QT interval in your ECG?
Sir, for dasatinib, sir.
Not for dasatinib, for any case.
Yes, sir.
What is the normal QT interval corrected?
Sir, the normal QTC interval, sir, it's between it's less than 480, sir.
All right. What happens if the QT is prolonged?
Sir, torsades de Pontis can be precipitated, sir.
Which TKS has got more significance with that?
Sir, nilotinib, sir. Nilotinib has out of the second generation TKS, sir.
Okay, go ahead.
Okay, good. So, yeah, and the other thing is autoimmune disorder. So if you have an autoimmune disorder, again, you're a little concerned with the use of dasatinib. Now, is there any data to say that dasatinib 50 mg can be used in these patients, or even lower doses, let's say 70 mg, 50 mg, or 20 mg? Is there any data to support the use?
There's a MD Anderson trial that was done, sir, in 81 patients, sir, and they found that, sir, the complete cytogenetic response was around greater than 90% at 12 years, and the MMRs was around 80% at 12 months, sir. So based on that, sir, we are even in practice, sir, we are using, sir, lower doses.
Yeah, but then I mean, look out for another study which got recently completed where this experience was not replicated in our context because of the fact that there is a higher proportion of patients who present with intermediate as well as high risk. So extrapolation of this data may not be correct. So I mean, anyway, look out. So right now this is the literature, but look out for more data. There's a manuscript which is, I mean, it's being written up right now, so we'll probably get to see that data in the next few months. Okay.
Sir.
So that's one. But is there any data with 20 mg dasatinib as well? Sir, in elderly patients, nevertheless. So in more than 70 years, people have used doses as low as 20 mg, and they've shown that at least 50-60% patients would still respond as well. Okay. So, I mean, what is the harm of using imatinib? Suppose I say that I decide to use imatinib. What is the harm of using imatinib here?
Sir, in this case, sir, there's a possibility of higher possibility of transformation into an advanced phase, sir.
Okay.
Sir, and
let's say that you take a general CML population of CML CP, okay, irrespective of the risk. And if I treat with imatinib 400 mg, what is the expected long-term outcome? How do you counsel a patient?
Sir, the expectable long-term outcome is, sir, it's around the same as that of the general population, sir. In terms of OS, sir.
Okay.
Sir, and sir, regarding taking imatinib, sir, sir, I would like to tell the patient that
No, not that. So let's suppose that you treat 100 patients of CML on imatinib, but at the end of 10 years, how many are going to be on imatinib and disease-free?
So 20% would be develop resistance or intolerance to.
Yeah. And another 10% will have, I mean, 20 to 30% will develop resistance or intolerance and will need a change of TKs. Or the 70% are expected to remain on imatinib and have the disease under control. Okay. The overall survival, of course, will be good, but on imatinib, 70% of them will remain on imatinib. Okay. This is an all-comer population of CML. Okay. Right. So how do you counsel a patient when you start on TKI?
Sir, sir, generally, sir, if the patient is, sir, in the reproductive age, sir, I would like to tell them to take contraceptives, sir, since the TKIs are teratogenic, sir. Sir, then
What contraceptives you prescribe?
Sir,
Why am I asking this question?
sir, because a drug interaction, sir.
There's a concern of drug interactions. So you have to look for drug interactions. Okay. Yes, you would advise them from against conceiving while on TKI.
Sir, I would
Okay,
strictly advise them
will you tell your patients?
regarding compliance and adherence to the treatment protocol.
Right.
Sir, the tablet has to be taken once a day. It has to be taken with food, and it shouldn't be skipped out at all. And the patient should follow up as said by the doctor at the pre-specified interval, sir. Sir, then apart from that, sir, of course, sir, the toxicities I would like to tell the patient about, sir.
Yeah.
Sir, skin rashes are very common, sir. Maculopapular skin rashes, sir.
Yes.
Muscle cramps are seen, sir. Diarrhea is seen, sir.
Yeah.
Sir, apart from that, fluid retention is seen, sir. And it is mostly temporary, sir. With treatment, it mostly subsides, sir.
Yeah.
Sir, apart from that, sir, myelosuppression can be seen, sir. QTC prolongation can be seen, sir.
Okay.
And now, once the patient is on treatment, you started her on dasatinib. How often are you going to practically monitor her in your center?
Sir, in our center, sir, till the patient achieves a complete hematological response, sir, we monitor 2 weekly, sir, with the complete count, sir, and with clinical examination, sir.
And usually, what time do you expect that to happen? Or when do you say that that's a failure if you don't get a complete hematological response?
Sir, 3 months, sir, is the cutoff, sir.
Within 3 months, if you don't get a complete hematological response, you will get to say it's a failure. Okay.
Yes.
Then?
Sir, then
would you do any other tests by 3 months?
Sir,
or
3
you're
months,
only
sir,
happy with the CBC?
no, sir. Sir, I would like to do a quantitative PCR ABL, sir, for the particular transcript that was found earlier on, sir. Along with that, sir, that itself is sufficient, sir. Along with
and what is the value that you expect to get?
Sir, sir, at 3 months, sir, I would be okay with at sir, 3 months, optimal value would be less than 10%, sir.
Okay.
How many log reduction is that?
Sir, less than 10% is equal to 1 log reduction.
Okay, actually more than 1 log reduction. Okay. And then you continue, if you achieve that level, you continue with the dasatinib. How many patients do you expect not to respond to that? Say if it's an imatinib era, you started her on imatinib, say. How many patients do you expect to develop a resistance or a primary resistance? You know that's a primary resistance.
Sir, I can't recall the exact percentage, sir.
Okay, so you know that's a primary resistance and a secondary resistance.
Sir.
If there is a resistance or at any point of time during monitoring, you found that you're not getting the adequate response, how would you intervene there?
Sir, if the adequate response is not obtained, sir, sir, I would like to do 2 things, sir. A bone marrow study should be done, sir. and a peripheral space should be done to ascertain if the patient has not progressed further into AP or BP, sir. Sir, apart from that, sir, at our center, from the peripheral blood sample, we do an NGS for mutation analysis, sir. And sir, from the bone marrow, also conventional cytogenetics to see if there's no additional cytogenetic abnormalities that have developed, sir.
Okay. You unfortunately, this patient developed resistance later, somewhere around 2 years down the line also. You did resistance mutation, and you got something called T315I. What would you do?
Sir, in this case, sir, the patient would be resistant to all generation 1 and generation 2 TKIs, sir. In this patient, then, sir, I can, depending on what my endpoint is here, depending on whether the patient is fit for a transplant or not. If the patient is not fit, and that's not the end goal, sir, I'd like to go for asciminib. If the patient is fit, sir, I would like to go for ponatinib. Put the patient into achieve a molecular response, and then take the patient up for transplant, sir.
Transplant. Ashmuk, anything else?
Yeah, no.
What are the long-term toxicity that explain being a 50-year-old lady, if she survives for another 20, 30 years, or 20 years, what are the long-term complications that you might expect? One is you mentioned cardiac complications. Okay, let's just to close wind up things. Let's just think about a young lady, in her 20s.
Sir.
Just married,
sir.
Diagnosed with
Sir.
CML. Any special things that you would means she's married, and then she wants to, after around 2 years of treatment, she comes to you, tells that she wants to be pregnant. What advice would you give?
Sir, I would, sir, is she, her response is, sir,
major molecular response.
Sir, I would like to, sir, if she's planning for pregnancy, sir, achievement of a treatment-free remission would be desirable, sir. Sir, in that case, sir, if she's on a first-line TKI, I would consider switching over to a second-line TKI, sir. And, sir, then I would counsel her that it is that she attains a TFR total treatment-free remission, and then attempt for the pregnancy, sir.
Treatment-free remission.
Sir.
She is now having a major molecular response of, say, like MR4.
Sir.
For the last, how long do you want for her to be in that status before stopping it?
Sir, she should have been on TKI for at least 5 years, sir. And the MR4 status should have been maintained optimally for around 3 years, sir, before stopping.
2 years also is good. Deep molecular response, if that's 4.5, you can have it at 2 years. So that's the reason why people might change to second generation TKIs if patients were in this thing. And for this patient, when in pregnancy, how would you monitor her?
Sir, during the pregnancy, sir, sir, I would like to, during pregnancy, sir, I would like to stop the TKI treat 2 weeks before when ovulation is suspected, sir. Sir, and during pregnancy, sir, I would like to definitely during the first trimester, the TKIs completely, all TKIs are completely not accepted, sir. Sir, I would like to monitor her blood count, sir, to see for her a burden, as well as for the, I would like to look at the quantitative PCR-ABL, sir. Sir, and based on that, sir, I would like to give symptomatic treatment, whether that's interferon, sir, whether it's leukapheresis, sir, whether that's if the there's thrombocytosis, sir, aspirin and low molecular heparin can be given, sir. So that is. Sir.
Dr. Sunu, I think
yes, we'll stop.
And Dr. Hasmukh, also any closing comments
No,
about the just for the
discussion? Yeah.
Yes. Any advice to our let's say our student, per se, would he be adequate? Any points or anything you want to add further?
No, I think it is good.
Okay,
That's good. I mean,
it was good. The only thing is that If possible, try to do repeated distance and make it a bit more faster. And that's the only thing. I think presentation, the concepts were clear. You knew the subjects, and definitely it was a good presentation.
Thank you very much.
Oh,
Thank you.
yeah, thank you. Thank you.
Thank
Sunu
you
and
to
Ashok, thank you. Thanks
Thank
from the
you.
behalf of Ampok for
Thank
doing
you.
the examination.
Thank you. Thank you.
thank you everyone, and we'll see you next month again. Thank you, Dr. Hasmukh and Dr. Sunu.
Thanks, sir.
Good night.
Good night.
Yeah.
Thank you.
Good night. Good night.
Good night.